Hi, welcome to Everything About Need PG, and today we're going to speak more about pediatrics. And in pediatrics, we want to speak more about neonatology. And first things, when we talk about neonates, I want to start with routine newborn care. Routine newborn care is so important. First of all, we need to speak about the 5 C's: clean cut, clean hand, clean surfaces, clean scissor, clean cord, and clean cord clamp. The 5 C's. Uh, I haven't written much about it, so I'll say it again: clean cord, clean surfaces, clean cord clamp, clean scissors, and clean hands, obviously. So, obviously, I'm not following a particular order, and that's pretty obvious. Next thing I want to speak about is chlorhexidine. Why do we use it? Maybe you can use it in suspicion of contaminations. Most cases you want to do a delay cord clamping for 30 to 60 seconds. Really important. In my opinion, one of the most important facts is that when do you not do a delayed cord clamping? So you don't want to do a delayed cord clamping, especially when you have RH antibodies. All right, so anti-D and you have your RH risk of RH immunization, isoimmunization, but they are not sensitized. If they are sensitized, that does not make a difference. All right. Second is that there is a cord compression or cord contamination and chorioamnionitis. And the other case that you do not want to do it is when you have asphyxiation or any kind of a trauma that warrants it. All right. The importance of cord clamping is obviously it provides for this extra RBCs and it prevents intraventricular hemorrhage, decreases the risk of intraventricular hemorrhage. So it can come as a true or false statement. Anemia and intraventricular hemorrhage, it's going to decrease. Next thing that is very important is something called as hypothermia. Hypothermia is so important because we deliver at 25 degrees Celsius. Some practices that we follow are no free air, skin to skin contact, immediate, and warm chain. What is warm chain? Warm chain is delivery, towel, and then again back to mother. You wrap up the kid and give it back. A very important thing that we need to do is vitamin K. Why? Because in neonates, your gut bacteria is really low, right? So you do not have gut bacteria, the good gut bacteria that produce vitamin K. So what you do is that you give 0.5 mg if it's less than 1 kg birth, and 1 mg if it's more than 1 kg birth weight. All right, you give it intramuscularly and your anterior lateral aspect of the thigh, and it prevents hemorrhage. It prevents hemorrhagic diseases in the newborns. So that is why you need to give vitamin K. Now, the next thing that we should speak about, very important, is erythromycin and tetracycline. When do you give erythromycin and tetracycline? Yes, do you give it actually? Yes, you give it erythromycin and tetracycline, TC and erythromycin, is when you have a gonococcal infection. And we've seen this in ophthalmology, and everything about ophthalmology we'll speak about when we come to the ophthalmology series. Today we're going to speak more about pediatrics only. Now, normal vitals in newborn, obviously your heart rate has to be 110 to 160. Again, I'm not writing that. Respiratory rate has to be 40 to 60. BP has to be 60 by 40 mmHg, and temperature has to be 36.5 to 37.5 in the axilla. Capillary refill time, CFT, is something that is usually missed out, is greater than 4 seconds is shock. Normal value 0 to 3. Obviously, this greater than 4 seconds is really important because you want to make sure that your baby is not on the shock. Weight loss in the baby in the first week is usually normal, and positing is something called as regurgitation of the feed. That causes vomiting of milk. That's also normal. So there's certain things that are normal. You need to understand is the weight loss is normal if it's 1 week, within 1 week, and second is the positing, POS, EITTING. Positing is also normal, which is basically vomiting, but in infants. Some normal findings in newborns that could be mistaken and comes as a may come as an MCQ is erythema toxicum, and neonatorium. You might just want to look at the pictures at the side. I did not add any images here because it did not strike me actually that we would speak about erythema toxicum, neonatorium, melanotic, pustular melanosis, maybe a little bit of Melias, Epstein pearls. All of these are certain findings. So erythema toxicum is there's nothing toxic about it. It is a normal finding. It's papillopustular lesion in the newborn and appears in greater than 24 hours. Very important. And over the chest and abdomen, very very commonly seen. It's seen with eosinophils positive. Actually, if you've seen a lot of kids actually have this erythema toxicum or neonatal. And there's also something called as pustular melanosis. Pustular melanosis are melanotic patches and pustules that appear at birth within 24 hours. Again, pustular melanosis. The difference is that here it's going to be neutrophilic and there's going to be more of pigmentation, melanotic patches, right? So again, that is also something that a lot of people have. Most of the kids get it, but erythema toxicum is something that I have seen. Other things that we can see is epithelial inclusion cyst, very common epithelial inclusion cyst. Something called as milia, which are like these milky spots. We've got Epstein pearls that are these are these white pearls on the palate, right? They're palatal pearls, and we've got something called as Bond's nodule. Bond's nodule is seen on the gums, nodules on the gums, and also something called as strawberry angioma and salmon patch. Strawberry angioma, salmon patch, and Mongolian spots. So to recap, erythema toxicum, eosinophils, papulopustular rash on back, and then you have something called as a melanotic pustules called as pustular melanosis, again neutrophilic, and as I've already said, that melanotic patches. Then you have epithelial inclusion cysts, again within 24 hours, and disappears on its own, nothing to do. Milia are these white spots, right? Milk-like spots, milk, as if you've seen milk getting heated up in a bowl. It's basically that. Epstein pearls are these pearls that are seen in the palate. Bond's nodule is seen in the gums. Strawberry angioma, salmon patch, or nevus, as you can say, is seen on the skin, anywhere on the face. Mongolian spots is usually seen on buttock. So again, that's also really high yield. So we've covered these kind of normal findings. Then we also can see breast milk, which is called a witch's milk, breast milk, because of estrogen, and estrogen kind of goes and stimulates the glands in the neonate to produce milk, right? So this is also again normal. It's milk plus breast engorgement was kind of looked down upon in the olden ages, and there can also be bleeding per vaginal if it's a woman, obviously, and acne. Other findings could be skin tags and physiological phimosis. Phimosis means the foreskin or is there's inflammation around the foreskin, and that is basically phimosis. Obviously, there's no need of explaining that. So skin tag and phimosis can be seen. Skin tag in females, obviously, I mean hymenal skin tags, hymen or vaginal skin tags, and phimosis in males. All right. Or obviously, there's something very interesting that is kind of high yield, which is called a harlequin color changes, and cutis marmorata. These are the two other cutaneous findings that you can see apart from Mongolian spots, strawberry angioma, Epstein pearls, Bond nodule, all of that. So harlequin and cutis marmorata. Again, very high yield. Once that is covered, there are two types of swelling in the newborns: caput succedaneum and caput cephalohematoma. Again, I'm not writing about it. It basically means that caput succedaneum is, importantly, it does not cross sutures, localized. Because it doesn't cross suture, that means it is it's limited by the sutures line, right? So if it's limited by the sutures line, that means it is superficial. Cephalohematoma is limited by the sutures line. I'm so sorry. Cephalohematoma is limited by the sutures line. It's separated by the sutures line. So it's very important to understand that it is associated with subperiosteal changes, subperiosteum. So because the periosteum have these suture lines, so subperiosteum area would also be limited by the sutures. Very important, can lead to it is basically hemorrhage. And second, it is seen in vacuum delivery. Third, it can cause jaundice, and it is seen 24 hours after birth. All right, not precisely immediately after birth, but 24 hours after birth. Very important. So it's deep, it's subperiosteal, right? So that means it's it's below the periosteum. That means it's between the periosteum and the bone. So it's so important. Then we have something called as a subglial hemorrhage. Now, this is something new, probably. I'm pretty sure most of y'all have heard it. Subglial hemorrhage is below the glial aponeurosis. Now, the glial aponeurosis is again the muscles. All right, the scalp has skin, connective tissues, aponeurosis, loose areolar tissues, and the periosteum. Now, below the periosteum is your cephalohematoma. Below the glial aponeurosis is subglial hemorrhage, and it is associated with vacuum delivery again. It's a lot of blood, could lead to jaundice, could lead to shock, could lead to hyperperfusion, diffuse in nature. And last but not least is capitis sedennum, capitis septenum. As the name suggests, it's superficial, it's below the skull, it's in the connective tissue. Period. Very important. Very important. Because of prolonged delivery, cephalopelvic disproportion at birth, soon after birth, and 48 to 70 hours. Certain important things again is neonatal reflex. Neonatal reflex are something that I need to speak about and a very high yield. First reflex to develop is palmar grasp. All right. So we'll speak about these into three terms: palmar grasp, or any reflex for the matter of fact, when it starts, fully developed, and when does it end? All of these reflexes. Palmar reflex starts at 28 weeks. All right, interesting. When does it fully develop? It develops at 32 weeks. So usually there's a difference of 4 weeks. I've seen this. There's a difference of 4 weeks. All right, and it ends 2 to 3 months. Postnatal, obviously. Most of these things are postnatal. Now, obviously, I'm not going to speak about the reflex ending in prenatal period. So, palmar reflex. Second is the rooting reflex. What is the rooting reflex? You stroke the skin and the baby kind of knows that, he has to suck there. When does it start? Again, it starts from around 22 to 32 weeks, anytime. Again, add 4. So, if it starts from the 32 week, it would usually end at 36 weeks. It would develop completely. So 34 to 36 weeks. Then it would end around. It wouldn't end, but it would become less prominent. It would decrease by 1 month. It doesn't end as such because breastfeeding definitely is needed. Then the other thing is motor reflex. And now the question is, what is motor reflex? Motor reflex is abduction and extension of the upper limb. All right. So when the baby is held in the prone position, okay. Sorry, when the baby is held in the supine position and it's allowed to fall. So there's going to be extension and abduction, followed by flexion and adduction. Now, when does that happen? Very simple. It fully develops. This is how I remember. It fully develops at term, which is 37. Now, the rule says that you should usually minus 4, right? Feeks. But this time you don't do that. This time, it starts at 22 to 32 weeks itself. The very same. And by 6 months, it kind of settles down. It reduces. All right? That's it. Then you have something called as an asymmetric tonic reflex. So basically, the side that the baby moves, the arm goes into extension and the other goes into flexion. Again, it develops by 35 months. Now there's no way of remembering this. And it's fully developed by 1 month postnatal. 35 weeks and 1 month postnatal. Stay still, 6 to 7 months, same. And then you have the parachute reflex, very important, is basically you're dropping the kid So he kind of extends the arms and legs to protect the face. So it kind of develops at 7 to 8 months postnatal and is matured by 10 to 11 months and stays for lifelong. So for the people who are just listening to this, Palmar reflex starts at 28 weeks, develops by 32 weeks, gone by 2 to 3 months. Rooting reflex starts at 28 to 32 weeks, fully developed by 34 to 36 weeks. Again, it's decreased by 1 month postnatal. Moro reflex, on the other hand, is fully developed by 37 weeks, gone after 6 months, and sorry, and you see it. When do you see it? You see it from 28 to 32 weeks. All right, 32. I don't know if it looks like 36 here for some messed up reason. You start at 28 to 32. Asymmetrical tonic, asymmetrical tonic neck reflex is starting. So it matures completely 1 month postnatal. That's something different. So you can remember that. It starts at around, again, 35 weeks, and it stays for 6 to 7. The parachute is interesting because it's completely develops by 10 to 11, and it starts at 7 to 8 months and stays forever. When you see absent Moro reflex, an absent Moro reflex shows that there's CNS malformation and encephaly, hypoxemic encephalopathy. Moro reflex persistent means show cerebral palsy. Unilateral Moro means kind of your brachial nerve injury, and yeah, so that is for your Moro reflex. There's another reflex called Landau's reflex, and again that also appears 3 months after birth and stays till 9 months after birth, which is basically flexion of limbs occurs on flexion of neck. So when you flex the neck, the limbs also undergo flexion. So that's Landau. So Landau is associated with limbs, all right? So let me just write that down as well, Landau. And I say that it develops 3 months postnatal and persists till 9 months, all right? Completely develops by 3 months, appears by 3 months, actually develops completely maybe by 6 months. And then we have the symmetrical neck reflex, which was before it was asymmetrical. The thing about symmetrical neck reflex is that it helps in crawling, STNR. What happens is that on neck extension, there's flexion of the upper limb, and then there's extension of the lower limb. It appears again by 4 to 6 months and persists till 8 to 12 months after birth. All right. So there are 2 other reflexes that are important. Okay. So once we've spoken about the reflexes, let's talk a little bit about care of low birth weight babies. The idea here is that, first of all, low birth weight babies have the following. Number 1, they are hypothermic. All right. Second, we need to provide them with nutrition. Why? Because they might be hypoglycemic. For all we know, they might just be hypoglycemic. So we need to do that. We need to provide them with nutrition. We need to make sure that at the particular weeks, we also do the particular correct method of feeding. All right. And we also need to make sure that the respiratory changes are taken care of, respiratory problems are taken care of in these kids. So first, care about the low birth weight is hypothermia. They are low on temperature, they are cold. The reason being that they have a bigger skull, smaller body, less brown fat. So you need to have a lot of brown fat. It's in the interscapular nape of region, anterior part of chest, kidney, all of that is gone. So the brown fat has a lot of mitochondria and smaller lipid vacuoles. That's all gone. The ways they can lose heat is conduction, convection, radiation, and evaporation. Obviously, all of that we know. The baby is extended. There's less brown fat. So the low birth weight baby is actually at quite a good risk of developing hypothermia. So how do we do it? obviously, there are three types of, or there are three grades actually when you're talking about hypothermia. One, we have anything less than 36 degrees Celsius is hypothermia. The normal temperature obviously is 36.5 and 37.5, right? So less than 36 is cold. So going from 36 to 36.4 is cold stress. All right, only hands and feet are cold, but obviously you need to take care, blanket or something like that. Moderate hypothermia, 32 to 36, less than 32, you're in severe hypothermia. Now, what should you do? What should you do? Cover the head of the baby. Kangaroo mother care. Uh, Low birth weight, hypothermia, preterm, you need to give kangaroo mother care. Very important, very important, very important. Important thing is upright posture, exclusive breastfeeding, and promotes exclusive breastfeeding, promotes early breastfeeding as well. So you need to do it for more than 1 hour, and you can do it for as much as you want till the baby has achieved its normal weight and reaches the term gestation of 37 weeks. Now, you could also prevent this hypothermia if it's very severe, less than 32, or if it's getting into severe, moderate hypothermia, but between 34 to 36, between 32 to 36, you could get into incubator or radiator. Now, if you're going into a radiator or a warmer, your heat is going by radiation and you're going to lose it by convection. But incubator, you're going to use convection and then radiation. Now, this is so stupid, but yeah, it's so important and so easy to mess up, right? Radiator, radiation, convection. The other is the exact opposite, convection, radiation. Next, nutrition. How do you do in nutrition? Less than 28 weeks, as I've already spoken, rooting reflex has just started. You're not into the rooting reflex. You know we're close to rooting reflex. You need to do total parental nutrition. Definite. IV fluid, 100%. In the 48 hours, 100%, 10% dextrose. After that, isolite P. Very important. Very important. How do you give it? First, 60 to 80 ml per kg. Give it day one. Gradually increase it by 10 to 20 ml per kg day, and till the upper level is reached, and then maintain at 150 ml per kg. So this is kind of important. So 28 weeks, total parental nutrition. Start with around 10% dextrose in your 48 hours, right? And then go to isolite P. What is isolite P? Isolite P is another very strong IV fluid. It's got a lot of substances. It's got phosphorus as well. It's got the important metabolic and electrolyte needs that you need. 10% dextrose is it's going to lead to a volume overload, maybe sometimes. So then you switch to more after 48 hours. You switch to isolite P. After that, so important. That we pump in, that we get the right nutrition. 60 to 80 ml per kg, right? On the day first, on day one. Then you increase 10 to 20 ml per kg. All right, till per day, till your upper level is reached. And what is your upper level? Upper level is your 150 ml. All right, so you can increase it till 150 ml per kg per day. Okay, so 60 to 80. I do not know if they would ask this. There's something called as a holiday Sager's formula, but that's again, we're going to look at it in dehydration, probably in this series as well. Next is 32 weeks. 32 weeks. The good thing about 32 weeks is that you've developed the rooting reflex, has appeared, but it's not completely developed, because I told you need to add a 4. So it's the rooting reflex 28 to 32 weeks, but 34 to 36 is when it completely develops. So you're greater than 32 weeks. It's a good thing. You can start with something called as nasogastric tube or NG tube, Riles tube, whatever you want to call it. Very important. Suck swallow breathing coordination is not developed. That's why you do not want to kind of give them by the belly day. From 32 to 34 weeks, you can go for the spoon feed or katori spoon, whatever express best milk you want to give in that form. Greater than 34 weeks, you should directly start breastfeeding, because your rooting reflex, your sucking is perfect. The sucking coordination, the uh, suck, swallow, breathing coordination is completely developed by then. So you want to go for breastfeeding. You want to make sure that they breastfeed. Nasogastric tube, how do you want to measure? Tip of nose, you want to go from tip of nose to earlobe and then to xiphisternum and umbilicus. Uh, between the xiphisternum and the umbilicus. So basically, you check this is the baby, the nose, the ear. If this is the xiphisternum, so basically this is the length that you want to kind of give, right? Maybe X centimeter plus Y centimeter. Maybe high yield, maybe not. Very important nutritional supplement. You want to speak about vitamin D. We spoke about vitamin K. Vitamin D in all babies, you want to give 400 international units per day. Why? Because it's deficit in breast milk. If it's 1.5 kg to 2.5 kg, or if it's less than 1.5 kg, let's speak about that. If it's 1.5 kg to 2.5 kg, you want to make sure that you give vitamin D of almost the same dose plus iron. Very important, because you might just be anemic. The baby might just be anemic. Second is that if it's less than 1.5, then you want to do the same thing. Vitamin D, 400 international units plus iron, that's 2 mg per kg per day till 1 year, right? And very important is human milk fortifier, right? You just want to give that as well. And you could also pump in a little bit of folate, calcium and phosphorus if low birth weight. Very important is, let's speak about hypoglycemia. So high yield, so high yield, so high yield. Because in low birth weights, hypoglycemia is such a classic thing. What are the symptoms? First of all, what is hypoglycemia? Hypoglycemia in neonates is less than 45. Period. Less than 45 is going to be a hypoglycemia. It could be symptomatic, asymptomatic. If it's symptomatic, obviously you want to speak more in terms of tremors, all right, and seizures and jitterness and lethargy, all of that. If it's asymptomatic, you want to check for the glucose level. If it's 20, less than 20, you're alarmed. If it's 20 to 45, you know what, you're yet alarmed, but you could go on oral feeds, because the baby seems fine. Reassess after probably half an hour. Check after 1.5 hour, half an hour. If there's improvement, voila. If no improvement, continue oral. If it's less than 20, straight up, you need to give IV. How much? 2 ml per kg, 10% dextrose. Always. All right. You need to make sure that you give 2 ml per kg, okay? IV bolus, and then you want to go for a continuous infusion of 6 mg per kg per minute of 10% dextrose. Again, high yield. So we've spoken about how we should give in less than 28 weeks. What kind of fluids we should give. We should start with 20 to 60, maybe increase up to 150 ml per kg. Start with 60 to 80 initially, right? If it's a low birth weight, go for 60. If it's a very low birth weight, go for 80 ml per kg per day. Increase by 10 to 20 ml. You could go up to 150 ml per kg per day to maintain. That's for less than 28 weeks. Obviously, then we need to follow as it is supposed to be. However, if you're talking about glucose, we need to speak about more in terms of about 10% dextrose using 2 ml per kg. Good enough. Trust me, it's good enough. And then we need to make sure that we are giving IV 10% dextrose at 6 ml per kg per minute, or 6 mg per kg per minute for continuous infusion. Next is that we should speak about is the hemat and respiratory problems that these infants could actually have, LBW. So if it's a hemat and if it's a preterm, I'm saying preterm, just preterm, you could have anemia, obviously, right? You could have respiratory ARDS, obviously. Sometimes in IUGR or low birth weight, because of IUGR, not because of preterm, the patient might also have polycythemia, in the sense that IUGR is causing a lot of stress. Stress is causing catecholamine release. Catecholamines are stimulating erythropoietin. Secondly, hypoxia is seen. Hypoxia is also stimulating erythropoietin, because of which polycythemia. Other thing that IUGR, very important, is meconium aspiration syndrome. Stress stimulates GI motility, which simulates meconium release and then eventually meconium aspiration. So again, that's really important. A few facts that I want to speak about. When do you screen for hypoglycemia? You screen for hypoglycemia whenever you have low glucose. So you're looking at something like preterm, low birth weight, IUGR. You screen. Secondly, you could check it in GDM patients, RH incompatibility, wherever you could have an insulin overdose, and infant and large for gestational age baby. Or you check in sick babies like neonatal asphyxiation, sepsis, and hypothermia. Right? You want to do a heel prick sample method of the blood taking in these neonates. You want to do it at 2 hours every 6 hours, then followed by 12 hourly on the 12th hour, then followed by 24 hours, and then by the 48th hour, to make sure that that the glucose levels are not falling. Right? You need to make sure that you keep the glucose level high. Roger that. Then let's speak about intraventricular hemorrhage. Intraventricular hemorrhage is collection of blood in the ventricles, commonly seen because these choroidal vessels are not well developed. They are fragile, and they break into the germinal matrix, and they bleed into the ventricle. So it's IVH. So the baby kind of has these dilated ventricles, congenital, in the form of congenital hydrocephalus. More importantly, the baby is sick, pallor, jaundice. So you need to check for do your initial investigation. Obviously has to be your neurosonogram, do a USG of the brain, then go for an MRI as a definitive diagnosis. And supportive treatment is fine. Very important is to intervene in the prenatal period by giving antenatal steroids. All right. So we spoke about intraventricular hemorrhage as well. So it's basically bleed into germinal matrix. The germinal matrix that surrounds bleed of germinal matrix into ventricle. But that's very chill, right? Okay, what is apnea of prematurity? Okay, apnea of prematurity is cessation of breathing. Why does it occur? For greater than 20 seconds or any duration. It's because of the immaturity of the brain, okay? So apnea of prematurity. So the brain is not developed. The respiratory system is not developed. The respiratory control system is not developed. So what's going to happen? Obviously, it's high yield to know that you're not going to be able to breathe. For how long? For 20 seconds. But is it going to be a problem? Yes, it is. And is it going to lead to cyanosis? Yes, it is. Is it as chill as a breath holding spell? No, it isn't. So how do you treat? You treat by caffeine. So caffeine is going to go stimulate the respiratory center of the brain and the medulla, or you could go for aminophylline. Now, what is an aminophylline? I think we all know what is an aminophylline. Okay, I do not want to get into it, okay. Very similar to caffeine, very similar. Theophylline, aminophylline, all of these drugs. Next, hearing defects in low birth weight. Cochlea might be damaged. First thing you want to do is you want to do a autoacoustic emission, all right, as a screen. Then if that is positive, all right, you fail in the response, then you want to do an AABR, that's an automated brainstem response. You want to see where in the brain, the response is not passing. And the confirmatory diagnosis is by BERA, BRA, brainstem evoked response audiometry. And all this is again there in the ENT high yield topics. Other thing that I really want to speak about is ROP. Again, it'll be there in ophthalmology. But ROP is when you use 100% hyperbaric O2, and there's immature retina, and it's an hyperoxic damage. All right, it leads to retrolental plasia. So there's fibrosis behind the lens, and kind of causing opacity. Second is that there is retinopathy as well because of immaturity of the retina. So when does this occur? It's a less than 32-week kid who you've given O2 in 100% O2 with assisted ventilation, and the kid was in a shock. You had to resuscitate by giving inotropes, and the culture also had a little bit of sepsis. So, sometimes to save something, you need to get rid of something. I mean, if it's a 32 weeks and a 1.5 kg, a low birth weight, right? Baby, there's a very high chance that ROP is there. Now, something interesting is that because it's such an ongoing process, the screening might just miss it. So, it's important that the screening is done 4 weeks or post 32 weeks. Okay, so if it's a severely preterm baby, 28 weeks or something, wait for 4 weeks, or do it after 32 weeks. Let's say you're not, even after waiting for 4 weeks, you cannot get to 32 weeks, don't screen. How will you screen? Do an indirect ophthalmoscopy, simple as that. How do you prevent? Make sure you give 90 to 95 O2. But now this is so less. I mean, we don't really see this. Doctors are smart. If you give 100% O2, probably you haven't studied only. Necrotizing enterocolitis, so important, so high yield. Again, preterm, terminal part of ileum affected, and ascending colon, so it's the ileocolon area that's affected. The risk factors is that you're premature, so pathogenic bacteria are there, the good bacteria aren't around, top feeds are given, and in term babies, if there is birth asphyxiation or maternal cocaine abuse or usage of H2, right? Anything that provides low blood flow, like cocaine or asphyxiation or hypoxia, there's going to be necrosis in that area. Or if you use anti-acids, again, there's going to be a lot of scenes because of decreased pH leading to colonization of the gut. So there's going to be necrosis. So necrotic enterocolitis, necrotizing enterocolitis is so easy, it's so simple. It's important to understand that there is going to be bacterial colonization, intestinal necrosis. Second stage is going to be simple. Because of necrosis, your mucus is going to erode, gas is going to enter, so you're going to see pneumatosis intestinalis, and that is exactly what stage 2A is. Then stage 2B is that this gas kind of goes into the portal veins. Now in stage 3, you might just rupture and you might have pneumoperitoneum. Stage 3B would be that, but stage 3A would actually be peritonitis because of, again, before rupture, you would be having a lot of inflammation that's proceeding into the peritoneum, right? So you would have peritonitis and pneumoperitoneum. So stage 1, you'd have normal imaging. There is blood and stools, there's abdominal distension, there's pain, there's discomfort, there's decreased bowel sounds, lethargy. 1A is occult blood, 1B is gross blood. Occult blood means you need to test the stool for blood. That's occult blood. All right. How do you want to treat? You want to do antibiotics for 3 days. Simple. Stage 2 is when you actually have a lot of metabolic triads. All right. Now stuff gets real. Your baby's sick, hypothermia, hyponatremia. You're losing a lot of fluids. So you're having a hyponatremia. You're having metabolic acidosis, abdominal wall edema, absent bowel sounds, all of that kind of stuff, and you're just low on platelets. So you're having thrombocytopenia. Stage 2A is pneumatosis intestinalis. So air is in the intestinal wall only. All right. Do not confuse it from pneumoperitoneum. Stage 2B is going to be more about pneumatosis portalis. So it's going into the portal system. Now, stage 3 is obviously going to be bounding rigidity, rebound tenderness, guarding, ascites, high intensity crying, severe, decompensated and unstable state of the baby. So 3A again, 3A is going to be your peritonitis and 3B is going to be your pneumoperitoneum. Now, how do you manage? First of all, stage 3, you need to go for surgery. Stage 3, you need to go for laparotomy, remove the necrotizing part, reanastomose. If unstable, primary peritoneal drainage is done. All right. Minimal enteral nutrition is advised post stage 3 surgery, so that and minimal breast milk is also advised. You should also give lactobacilli. Now, if it's up to stage 1 or stage 1A, you give it for 3 hours. You give it for 3 days. That's good enough. For 1B, what you need to do is you need to make sure that you give antibiotics for 7 days. And for 2A, all right, for 2A, you need to for 2A, you need to make sure that you give antibiotics for 14 days. All right. For 3A, also, you need to make sure that you give antibiotics for 14 days. If this makes sense. Because stage 1 is so basic, stage 1A is just occult blood, so you give it for 3 days and you're good. Stage 1B, you could give from 3 days to 7 days. Depends. Stage 2, because it's just pneumatosis intestinalis, you need to make sure that you give it, though you can give it for only 7 days. It's fine. Trust me. 7 to 14 days. If it's stage 2B, you can give it for 14 days. If it's stage 3A, you can give it for 14 days, because 3A is just peritonitis. All right. So that is neonatal complications. Now, sometimes there is obviously neonatal resuscitation that we need to follow, and this is something I'm gonna just cover in like really quick, because number one, it's so high yield. So neonatal resuscitation. First thing, algorithm wise, first you need to do this TABC. Okay, TABC. So first, check for temperature, initial assessment. All right. Check for cry, term, tone, everything. All right. If the tone, cry, wagera was normal, we wouldn't even get into the neonatal resuscitation, obviously. So tone, first of all, so first initial assessment, check for temperature, check for hypothermia, wagera. As I said, 36 degrees ke niche, 36.5 ke niche, it's hypothermia, or 4, cold stress. I hope you understand what cold stress is. Temperature, check for secretions, check for suctioning, check for position. First position the baby in the sniffing position, then do the tactile stimulation, obviously, and see if breathing is occurring. If no cry after initial assessment, then assess the heart A. So airway, so you check the airway, obviously by doing the suction and all of it, right? You've checked the airway, right? And surprisingly, there's nothing. Yet no response. Check breathing and circulation now. So how do you do it? So the normal heart rate is around 120 to 160. I also say 110 to 160 now, because 120 or 110 to 160. So you check the heart rate. If there's a decrease in heart rate, the entire algorithm changes. Okay, so if the heart rate, okay, is less than 100, and then there is one when the heart rate is greater than 100, first check the heart rate. If the heart rate is less than 100 or greater than 100, now if the heart rate is less than 100, you are in a soup, in a tight condition, because your heart rate is less than 100 and you're not breathing. I mean, yours and the kid is not breathing. So what do you need to do? You need to do positive pressure ventilation. Positive pressure ventilation, you could go for bag and mask, or you could go for endotracheal invasion. Whatever. You could go for bag and mask, and you could go for endotracheal. Bag and mask, you'd have to pump, obviously. Endotracheal, you need to directly go into the trachea, probably get a cricothyroidectomy. If it's greater than 100, obviously, and again you're hypoxic, labored, and your cyanosis is seen, so then you need to figure out, you need to do two things. One is O2 hood, and the other thing is you need to do CPAP, continuous positive airway pressure. Now, if less than 32 weeks, because CPAP keeps pressure positive, so you should do CPAP if it's less than 32 weeks. You can give O2 hood, but do you really give it? You would obviously prefer CPAP, because you don't want your lungs to collapse, right? So you again want to give continuous positive airway pressure, like how we are giving in positive pressure ventilation. But we are doing positive pressure ventilation in the form of bag and mask. Bag and mask is easier than endotracheal tube, right? Obviously, for obvious reasons, as it is non-invasive. Now, if no response after assessing heart rate and respiratory, okay, you need, and we are doing this within 30 seconds, all right? We're doing these next steps have to go. Now we are going to check it from 30 seconds. So if within 30 seconds there's no improvement in heart rate, what do? You start heart compressions, and you make sure that your heart compressions start when your heart rate drops below 60. All right, you need to make sure that your heart rate, so now if your heart rate is less than 60, you need to make sure that you give compressions, and the compression ratio is going to be 3:1. So 90, right? 90 chest compressions plus 30 breaths. Usually you're using your bag and mask ventilation, so you do that. The superior technique of giving it is two-thumb technique, but you could also give it two-finger technique. All right, now in your next 30 seconds again, you analyze in your next 30 seconds again. Within 30 seconds, what has happened? Heart rate better, not better? If it's better, obviously you need to again stabilize. Again, you need to come back to your respiratory changes. You need to check for, is your breathing better? Is your heart rate now getting better? Are you cyanotic? Is the kid cyanotic? Is the kid not cyanotic? The kid is getting better, remove from CPAP. Whatever. We need to see that. Second, after that is obviously you need to make sure that you administer adrenaline if your heart rate is less than 60 yet. So you need to give IV route adrenaline, and your dose is going to be 0.3 ml per kg per dose, and it's going to be around 1:10K. Okay, very important. You can also give endotracheal, you can also give interosseous. Interosseous would become 0.2 if you're giving interosseous, probably in the sternum, but IV is fine. No response, okay, yet no response, you need to give volume expansion, give IV fluid, check for blood loss, anything, need to check it. So that is the basic idea of getting around with the entire neonatal resuscitation. Now, there's one thing that we need to understand about bag and mask ventilation. All right, now bag and mask ventilation might just be not is life-saving in most cases, but what you need to do is that if your bag and mask ventilation initially does not show any show a good response, and if it's non-invasive, obviously. uh if it doesn't show a response, you do your mask readjustment. You reposition your head. All right, you readjust the mask, you reposition, you do suction, okay, open mouth, and then probably you might have to take an alternative airway. So that is why the ideal way is to cover the mouth and the nose. Make sure that there's no secretions. Very important. And very important again is we need to make sure that we have the other alternative airway like endotracheal as the last stage. Okay. Uh, the rate that we should do BMV, bag mask ventilation, is 40 to 60 per minute initially. Then when you're getting cardiac compressions, then you need to follow 30 to 90 to 60 90 to 30 ventilations. But initially you need to make sure that it's 40 to 60 per minute, because that is the physiological respiratory rate. First breath is 30 to 40 centimeter of water, because the first breath has to open everything. Then the pressure is going to be 15 to 20 centimeter, 15 to 20 centimeter. It's very important to understand the SpO2 that you want to target after every minute. So 1 minute you want to give an SpO2 of 60 to 65. Never will you ever actually reach an SpO2 of 100% because of risk of ROP, retrolental fibroplasia, and retinopathy. So that is again something very important. And you should also be ready for endotracheal tube intubation, right? So in a summary, the kid is born, not breathing. First thing, check temperature, check airway, check the breathing, check the circulation. First things first, check the temperature, check the airway, suction it out, whatever. Put it in a stiffing position, put the baby around, flicker, tap, tactile stimulation. Not helping, go for your assessment, check for your heart rate. Less than 100, whatever. Hypoxia, right? First thing that's going to change in hypoxia, what do you see? First thing that's going to change your heart rate, obviously. So you need to check, right? First you check for breathing, exactly. So how do you check for breathing? You check for heart rate for breathing. Are you going to go and count the amount of breaths that the baby is taking? What if the baby is hypoxic and he's not showing any changes in the skin? You can't take the risk. So go for it. Go for bag mask ventilation or your endotracheal tube intubation, or just, go for your CPAP or your O2 hood. You never know what's gonna work. You never know. But you need to make sure that you usually have positive pressure ventilation, all right? Okay. And then you need to, if yet the heart rate has fallen below 60, you know what? You start heart compressions, 30 seconds. Within 30 seconds, go for your adrenaline, 0.3 or 0.2. You decide. Make sure that the dose is 1:10K. Somehow it's not happening. Check for your bag mask ventilation again. Suction it out. Go for an alternate airway, endotracheal. After 20 minutes of completions of all these resuscitation, stop. The baby's dead. All right. Make sure your SpO2 is matched according to the minutes. 1 minute you want to go 60. 3 minutes you want to go 75. 2 minutes you want to hit 70. 4 minutes probably you want to just scrape around 80. 5 minutes you want to go for 80 to 85. 10 minutes 90, 95. That's it. Never give it in a congenital diaphragmatic hernia. Bag mask ventilation is not good. First breath, keep a high pressure around 30 to 40. Second breath, get it to 50 to 20. That's about it. If it is about a meconium stained liquor, and if the baby is crying, he's vigorous, you're happy. If the baby is not crying and heart rate is less than 10, follow the usual steps. Obviously, continue for your early pressure ventilation. And do not it is said that do not do your suctioning, even if it's an MSL, because in the process of suctioning it out, though it obviously has a ball valve phenomena, uh, you could do that later after stabilizing the patient. So that's really important. First, stabilize the patient, no matter what happens. Then we have the ABGAR score, so important, max 15. You need to have a 15 score of 15, very important in my opinion. ABGAR, appearance, pulse or heart rate. G is your grimace. Again, A is your activity or posture. Uh, uh, R is your respiratory effort. So appearance, if it's pink, 0. Sorry, if it's I'm so sorry. Pink, it's 2. Partial cyanosis, 1. Full cyanosis, 0. Sorry, I don't know why did I say 15. GCS is 15. ABGAR is out of 10. It's just dumb. My bad. So again, yeah. So 0, 1, 2, ABGAR. You need to make sure that your appearance is pink. Give him a 2. Partial cyanotic, 1. Complete cyanosis, 0. Pulse rate, 0, 0, 0. 1 is less than 100. More than 100 is 2. Grimace, no response, 0. Weak response, grimace is 1. And cry, good cry is 2. First time you want a baby to cry is this, and that's the last time. Activity, if you're in flexion, you're 2. If you're in partial flexion, 1. If you're in complete extension or loss of tone, 1. 0. Respiratory rate, no response, 0. Less than 40, labored breathing, 1. Strong respiratory effort with cry, you're at 2. All right. So that is about it for most of the things that is associated with neonatal respiration and neonatal resuscitation, neonatal conditions, and probably the next thing that we speak about is neonatal sepsis, early onset, late onset, birth asphyxia, and neonatal seizures. And obviously, we'll also speak a little bit about respiratory distress syndrome in the newborns, with a little bit of normal growth here and there. That's about it.